morning. I'm Ashwin Kumar. I'll be
Good morning. Good morning. I'm Dr. Ashwin Kumar, Junior Resident in the Department of Emergency Medicine. I'll be discussing on the topic atypical and viral pneumonia under the guidance of Johnson Sir, Additional Professor in the Department of Emergency Medicine. So first of all, let us start with the definition of pneumonia. What exactly is pneumonia? Pneumonia is infection of a lung parenchyma which results from proliferation of lung pathogens and the post-inflammatory response to those pathogens. And broadly, pneumonia can be classified into three categories depending on where the patient acquires the infection. Into community acquired pneumonia, hospital acquired pneumonia, and ventilator associated pneumonia. In community acquired pneumonia, the patient acquires the disease from the community and he has not been in contact with the hospital setting in the last 14 days in catching the infection. In hospital acquired pneumonia, the infection of the lung parenchyma occurs after 48 hours of hospital admission and the patient should not be in incubating period at the time of admission. In ventilator associated pneumonia, the infection of the lung parenchyma occurs 48 hours after endotracheal intubation. Previously, there was yet another term called healthcare associated pneumonia, but now they have done away with that term and healthcare associated pneumonia has been covered under hospital acquired pneumonia only. All infections do not result in disease. Why? Because we have host defense mechanisms which protect us from getting the disease. These host defense mechanisms include the hairs and the turbinates of the nares, the gag and the cough reflex. The mere branching of the trachea completely is also one of the defense mechanisms that prevents us from getting the disease. The mucociliary clearance and the alveolar macrophages and the surfactant proteins. The surfactant proteins A and B are involved in protection against these lung pathogens. So what are the signs and symptoms that the patient with pneumonia would have? The symptoms would be fever, chills and rigor, cough with or without expectoration, shortness of breath, chest pain, confusion, altered mental status. And signs that can be elicited from the patient include tachypnea, increased work of breathing, tachycardia, crackles, wheeze, bronchial breath sounds on aspiration, pleural friction drop, dullness to percussion, or increased vocal fremitus. In addition to this, patient can have non-specific symptoms like nausea, vomiting, diarrhea, headache, malaise, myalgia, which have been highlighted in red. So the symptoms that are being given in black are typical symptoms that we expect a patient with pneumonia to have. Those which are highlighted in red are atypical symptoms and they are caused by pathogens which are referred to as atypical pathogens. So what are the etiological agents? Depending on the place where the patient has acquired the infection, the etiological agents will vary. If the in the outpatient setup, the most common etiological agent is the pneumococcus or the streptococcus pneumoniae and the Haemophilus influenzae. But since widespread vaccination is now already being done, Haemophilus influenzae is not that prevalent. In outpatients, we also have Mycoplasma pneumonia and Chlamydophila pneumonia, and the respiratory viruses span over the entire spectrum of non-ICU, ICU, and outpatients also. One thing that has to be specified in particular is in ICU patients, they can have Legionella infections, and non-ICU patients, they can have chlamydia infections and Legionella infections, which are atypical agents. Whatever is highlighted in red is the atypical agents. What are the X-ray patterns that we commonly expect in a patient with pneumonia? So, low-bar pneumonia. In low-bar pneumonia, it's commonly seen in community-acquired infections like pneumococcus. And the infection over here starts in the air spaces, that is the alveoli, alveolar ducts in the air spaces. And there is a peripheral focus of dense opacity and sparing the large airways which lead to the production of bronchograms. This is just X-ray PA view of a patient with right upper lobe. This is the chest X-ray PA view of a patient with right upper lobe pneumonia. Right upper lobe pneumonia. This is the chest X-ray of a patient with a chest X-ray PA view of a patient with right upper lobe pneumonia.
Okay, anything else?
Sir, in addition to the
Any additional comment? So she said that there is a non-homogeneous opacity. Where it is present, Mayuri?
Right upper lobe, upper
See,
zone.
whenever you read a X-ray, so you don't say it is lobe here.
Upper
You
zone.
have to say it is upper zone, mid zone, or lower zone. Correct? So as per zones, which zone it is?
Right upper zone.
How do you divide upper zone, mid zone, and lower zone?
Ribs by counting
Ashwin?
2 to 4 ribs.
Upper zone?
here we are able to appreciate the horizontal fissure.
The question is up to what is you say it is upper zone? Yes. Any idea? Yeah. Yeah. Correct. So up to 2 it is the upper zone. Okay. Then becomes the mid zone. 2 to 6. And beyond 6 is the lower zone. Okay. So upper and middle zone it is actually the non-homogeneous opacity. So lobe and zones are not synonymous. Huh? So when you present, you please say it is a zone in X-ray. Huh? On examination, areas. Then final inference you can say upper lobe, middle lobe. You understand? Apical-posterior segment also you can say. So not on the X-ray. Huh? Chalo. Bulging fissure sign, that is very common. Right.
So as sir discussed, we are able to appreciate the horizontal bulging fissure sign, bulging of the horizontal fissure, and the air bronchograms are also very prominent in the opacity. So this is likely secondary to Klebsiella pneumonia. Another category that we can see appreciate in the X-ray in a patient with pneumonia would be a bronchopneumonia pattern. Here the infection originates in the airway and then spreads to the air spaces. The patient will have multiple patchy areas of consolidation which will ultimately coalesce as the disease progresses. Here the patient will not have any air bronchograms. Yet another chest X-ray peer view showing a patient with bronchopneumonia. Here there are multiple patchy opacities and there are no air bronchograms that can be appreciated. There are multiple patchy opacities on both aspects of the lung. And if this patient was not receiving treatment, it should progress further to coalesce into large patches.
So I would say why not it is pulmonary. How do you define it?
Sir, if it was pulmonary, there would be capitalization of the vessels. And if it was secondary to any heart problem, ultimately would have also been there. And so we saw the lobar pneumonia and the bronchopneumonia. Lobar pneumonia was involving the alveolar spaces and bronchopneumonia was involving the airways. Now there is yet another portion of the lung which is the interstitium. This type of pneumonia involves the interstitium and is referred to as the interstitial pneumonia. Viral pneumonia usually presents like this. So this is a chest X-ray view of the patient. This is the chest X-ray view of the patient. Here the trachea appears to be middling and it is not a rotated film, it is a normal film and there is no... okay. We can appreciate the bronchospheric markings on either sides of the lung here and these are predominantly seen in the subpleural aspect rather than the entirety of the lung. So likely an interstitial pattern on a X-ray. It could be interstitial pneumonia, it could be interstitial lung disease also.
You can see reticular pattern. Normally reticular like reticle. Then normally bronchospheric marking up to the 2/3 of the lung. Large concentrated margin. So you can see reticular are also important. It is reticular nodular pattern. Okay. So one of the differential is interstitial pneumonia, even interstitial lung disease. ILD can present to you like this, right? But in ILD there will be already volume loss because of shrinking lung syndrome. Okay, SLE, rheumatoid, okay, all these autoimmune disorders will have associated ILD, or idiopathic pulmonary fibrosis is also the thing. But there will be a volume loss. Means the rib crowding will be there on both sides, and it will shrink. But here volume is lung volume is all right. That is how you differentiate, okay, between the two. Okay, and secondly, in ILD, the diaphragm will be almost equal on both sides because there is a volume loss. It is also called as a vanishing lung syndrome. Okay, so that is how you differentiate from an acute condition from a chronic condition. You understood? Huh? So this can be very tricky. Take it over. Continue.
So how do we triage patients with community-acquired pneumonia? We have the CURB 65 score. In the CURB 65 here refers to each point is given to one of the parameters. C refers to confusion, and here it is given as urea. It is blood urea nitrogen, and R refers to respiratory rate, blood pressure of less than 90 over 60 mm of mercury, and age over 65. Depending on the cumulative score that the patient gets, we can decide the level of treatment that the patient is going to receive. If the score is between 0 and 1, the patient can be safely discharged to be on outpatient treatment. If the score is 2, the patient can either be treated as inpatient or as outpatient with close observation. Any score more than 3, patient has to be managed along ICU units only. However, a score of 1 and 2, and the score is partly or entirely attributed only because the patient is greater than 65 years old, then we can manage the patient on OPD basis only. This is yet another triaging tool that we have, the pneumonia severity index. Although it is very, this is yet another triaging tool, the pneumonia severity index. It is difficult to calculate, but MDCalc gives this option, and we can calculate it in MDCalc. So it depending on several parameters, it divides the patient into 5 different classes, class 1 to class 5. Class 1 and 2, patient can be managed on outpatient basis. Class 3, patient can either be managed on outpatient or inpatient basis. And class 4 and 5, patient has to be managed on inpatient basis only. Both CURB 65 and pneumonia severity index can be used in the triage of patients, but data supports that we use a pneumonia severity index only. These are the other commonly used scoring systems in addition to CURB 65 and pneumonia severity index that we have. The SCAP prediction score, CRP 65, risk of early admission ICU index, SmartCop, CAP-PIRO, and American Thoracic Society major and minor criteria. So this is the American Thoracic Society. This is the American Thoracic Society major and minor criteria to say when the patient is having a severe community-acquired pneumonia. It has major and minor criteria. In major criteria, the patient should either have 1 major criteria or 3 of the minor criteria mentioned here. In major criteria, if the patient is having respiratory failure that requires mechanical ventilation, then he would go into severe community-acquired pneumonia. Or if the patient is having severe shock that is requiring vasopressors, then the patient would be classified as a severe community-acquired pneumonia. However, if the patient is having a shock that is fluid responsive, then it would be one among the minor criteria. And the other things that are present in the minor criteria are blood urea nitrogen more than 20 mg per deciliter, confusion or disorientation, elevated core temperature, lymphopenia of leukopenia of less than 4,000 cells per microliter, which should not be secondary to cancer chemotherapy. Here the leukopenia that the patient sustains must be secondary to the disease and not secondary to the cancer chemotherapy. Now going to the core topic as such, atypical pneumonia. Atypical pneumonia, this syndrome was first described in 1930s when a group of patients were found to have milder symptoms which could not be explained by pneumococcus, Haemophilus influenzae or Staph aureus. It was an indolent disease with a gradual onset and could not be detected on routine smears or cultures, and all of these agents are resistant to beta-lactam antibiotics. This is a table that has been taken from Fishman's Pulmonology showing the causes of atypical pneumonia. Here, the causes include Mycoplasma pneumonia, Chlamydophila pneumonia, Chlamydophila psittaci, Legionella, Stella, Yersinia pestis, Bacillus anthracis, and array of respiratory viruses, and Coxiella burnetii also. Here, my discussion will be limited to Mycoplasma pneumonia, Chlamydophila pneumonia, and Legionella pneumonia. This is a table that shows differentiation between So this is a table that shows different. So this is a table showing the differentiation between typical and atypical pneumonia. How to differentiate typical and atypical pneumonia? On the basis of clinical course, a typical pneumonia would have an abrupt onset, whereas a atypical pneumonia would have an indolent and a gradual course. Symptoms in a case of typical pneumonia will usually be confined to the lung, whereas in a atypical pneumonia, patient will have many extrapulmonary symptoms also. And patient might have a dry cough with a scanty sputum. Leukocytosis is usually present in a case of typical pneumonia, whereas in a case of atypical pneumonia, it may or may not be present. Staining and culture, we will be able to identify the causative organism in the case of typical pneumonia, whereas in atypical pneumonia, with routine staining and cultures, we will not be able to isolate any organisms. On chest X-ray, as we had already discussed, a typical pneumonia would usually present with a lobar or a bronchopneumonia-like pattern, and a atypical pneumonia will have interstitial opacities. Course and prognosis. In a typical pneumonia, the patient will have significant mortality. The patient might have significant mortality despite treatment, but atypical pneumonia, even without treatment, certain atypical pneumonia tend to get cured on its own. This is a table showing a prevalence of atypical pathogens in community-acquired pneumonia. One of the columns shows worldwide prevalence, and one is the prevalence that has been documented in India. Here, one thing that we have to note is that Mycoplasma is the most prevalent atypical pneumonia among Mycoplasma, Legionella, and Chlamydia at the worldwide basis, and even in India. However, when we see the prevalence of atypical organisms causing severe community-acquired pneumonia, Legionella takes the predominance. Sir, 3 studies in India have been done, sir. 2 in AIIMS and one in Delhi hospital. So can we predict that the patient could have an atypical pneumonia? So yes, we can predict that the patient could have an atypical pneumonia, but what was the necessity to predict that the patient would have an atypical pneumonia? First, let me give context regarding this. So this is the Japanese Respiratory Society score. In Japan, there was a large resistance to macrolides among the pneumococcus. And so among atypical organisms, to cover atypical organisms, we have to give the patient macrolides. So if they irrationally start using macrolides, there would be resistant organisms among pneumococcus that would flare up. So they came up with a score. Initially, the score had 9 parameters in 2000, which was streamlined to have only 6 parameters now. These 6 parameters include age less than 60 years, no or minor underlying diseases, a stubborn, which is a persistent cough, limited chest auscultatory findings, cough without expectoration, and no agent has been identified on a rapid diagnostic test. Here, and the WBC count of less than 10,000. As we had already discussed in the differentiation between typical and atypical pneumonia, leukocytosis may or may not be present. Here, we have not taken leukocytosis into account at all. So a score of more than or equal to 4 is more predictive that the patient could have an atypical pneumonia, so they could start the patient on empirical cover with macrolides. Like the curve 65 score, this is the CAS 75 score. Like the curve 65 score. Sir, actually, it has a very limited 77% sensitivity and 93% specificity, sir, to predict that the patient could be having an atypical pneumonia. But the validity of the study is not that good, sir, in outside population.
What is the relevance of this score in countries like us?
So, like the CURB 65 score, we have the CAS 75 score also, which predicts whether the patient could be having atypical pneumonia. Again, even this study has poor external validity. No, sir. No. Like CURB 65 score, we have yet another score with a number.
It is a like-to-like score, it is not that.
Okay.
Curve 65 with pneumonia is a like score is pneumonia severity index. And pneumonia severity index scores over the curve. That is what it is. The message here is it is not a like score. You know, here you are talking about atypical. So you stick to that.
Okay. This is the CAS 75 score, again to predict whether the patient could be having atypical pneumonia, with poor external validity only. Here, each of the letters stand for different things. C for the absence of chest pain, A for contracting the disease in autumn, and S for sodium less than 135 milliequivalent per liter, H heart failure, and 75 refers to age less than 75 years. As the score goes on increasing, the likelihood that the patient is having atypical pneumonia increases. Again, this study has a very poor external validity. Now we will discuss about the agents in specific. Now I start with Mycoplasma, which is the most prevalent atypical pathogen. So Mycoplasma is commonly referred to as the latent agent pneumonia, causing latent agent pneumonia, walking pneumonia, or primary atypical pneumonia. Its transmission is through respiratory droplets. It usually causes a flu-like illness. The patient will have non-specific symptoms like running nose, fever, which usually settles on its own without treatment also. Patient will have a cough with scanty sputum, shortness of breath, headache, malaise, and arthralgia. A silent hypoxia may be seen in the patient. Physical examination may reveal rales and pleural effusion might be seen. As far as Mycoplasma is concerned, even without treatment, the patient tend to do good only. But as already discussed, atypical pathogens can cause extrapulmonary. They are known to cause extrapulmonary manifestations, and Mycoplasma is also known for that. The hematological extrapulmonary manifestation that we can see in Mycoplasma is the immune-mediated hemolysis that the patient could have, or a disseminated intravascular coagulation that the patient could develop. Mucocutaneous manifestations, a patient could develop a reactive infectious mucocutaneous eruption or maculopapular rashes. In hematological, cold agglutinin disease could also be there in the patient. These are the other extrapulmonary manifestations that have been represented here. The cardiac manifestations, patient could have myocarditis or pericarditis. Insignificant involvement, encephalitis can happen, meningitis can happen, acute demyelinating encephalomyelitis can happen, Guillain-Barré syndrome can happen, and patient can also go on to develop hepatitis, arthralgia, myalgia, and pancreatitis. This acute demyelinating encephalomyelitis and GBS are immune mediated. So, management of atypical pneumonia. All atypical agents are resistant to beta-lactams, and they will be responding to macrolides, doxycycline, and fluoroquinolones. And Mycoplasma pneumonia is not any such different. It will respond to macrolides, doxycycline, and fluoroquinolones. In places where there is low resistance for macrolides, you can start the patient on macrolides. Example in United States. And if our country sees high macrolide resistance is there, you can take the patient on doxycycline, sir.
We have high microlide resistance in India.
Sir, I'm not. Actually, I don't have the data now, sir, but here macrolide resistance is in India. But, So if there is resistance as discussed in Asia and some parts of the world, we can go ahead with doxycycline or respiratory fluoroquinolone. Again, levofloxacin is one of our second-line drugs for TB, so we rather go for doxycycline only. For the extrapulmonary manifestations the patient will be having, the immune-mediated extrapulmonary manifestations, demyelinating encephalomyelitis and GBS, you can go ahead with steroids, Plex and IVIG. And the immune-mediated hemolysis, that is much. Patient is presenting with a non-specific upper respiratory tract symptoms followed by new onset weakness, bowel bladder disturbances, and motor weakness, and automental status also. The immune-mediated hemolysis, that is mycoplasma pneumonia related, is usually self-limiting. However, if it goes on to be severe, we can consider steroids or Plex for the patient. The next agent that I am going to be discussing is Legionella. Legionella is one agent that is among the atypical agents, is capable of causing severe disease, even ARDS. It causes a spectrum of manifestations ranging from Pontiac fever to severe Legionnaires disease with extrapulmonary manifestations. Pontiac fever is a self-limiting acute febrile illness that usually resolves even without treatment. And Legionnaires disease is the severe form of Legionella pneumophila. The patient might go on to develop acute respiratory distress syndrome with other extrapulmonary manifestations also. What are the extrapulmonary manifestations that the patient can have? Patient can have nausea, vomiting, diarrhea. On central nervous system, patient can have meningitis, brain abscess, cardiovascular system, myocarditis, pericarditis, septic arthritis, and one peculiar feature of Legionella pneumophila is that the patient will be having a hyponatremia, and transaminitis can also be seen. Again, management. Here the agent preferred would be levofloxacin or azithromycin. Both levofloxacin and azithromycin have high bactericidal activity and they are active against all Legionella species. Doxycycline is not preferred if we are suspecting Legionella longdiac, but Legionella pneumophila serotype 1 is the disease that causes severe pneumonia, and that is covered by levofloxacin and azithromycin. And there are studies to show that combination therapy has no improved outcomes in patients with Legionella pneumophila. In refractory Legionella pneumophila, we can consider tigecycline for the patient. Usually with treatment, patients respond very well, and the fever patient goes into apyrexia over 2 to 3 days. So this was a systematic review and meta-analysis of several RCTs that was done, and to compare whether, so here we see agents prefer levofloxacin and azithromycin. So here they compared fluoroquinolones and macrolides in this meta-analysis, and they went on to find similar effectiveness in reducing mortality among patients with Legionella pneumophila. That is, you can use either of these agents, there is no difference. Diagnostics on chest X-ray. So this is the table that I've taken from a study which was done on a paper which was published on atypical pneumonia. So in mycoplasma pneumonia, a peculiar feature would be reticulonodular opacities that we would be able to appreciate on the X-ray, and the peribronchial cuffing. I have the X-ray, I will show it in the slides. And in Legionella pneumophila, patient would have a lobar consolidation, and multilobar involvement might also be seen in the patient. And the pleural effusion is very much common in Legionella, and pleural effusion can be seen in the case of mycoplasma pneumonia also. In chlamydophila pneumonia, usually a sublobar consolidation is seen in a chlamydophila pneumonia, and it usually involves the basis of the lungs. So this is an X-ray of a patient with mycoplasma pneumonia. This is an X-ray of a patient with mycoplasma pneumonia showing the peribronchial cuffing that the patient is having. Significant bronchus can be appreciated over here, and there are interstitial opacities that can be seen that with a predilection towards both the lower lobes here.
The important thing is that most of the time it displays the upper lobe.
Here, this is an X-ray of a patient with chlamydophila pneumonia. So as I already discussed, the patient will have a sublobar consolidation, which has again predilection for the lower lobes only. This is a patient with Legionella pneumophila infection. Here, this Legionella pneumophila is one of the bad atypical mycobacteria which is capable of multilobar involvement. Here, the patient is having a hilar opacity, and even with treatment, the patient went on to develop multilobar consolidation.
What is that? Can you go and look and
So this is a series of X-ray that was taken in a patient who was infected with Legionella pneumophila infection. This was the initial.
So most of the time what happens that in atypical pneumonia, the lesion will involve the parahilar region or subhilar region, and it will involve the lower lobe most of the time, or sometimes middle lobe. It will spare the upper lobe. ठीक है ना? It may be associated with pleural effusion in some of the cases. In up to 10 to 25% cases, it may be associated with ipsilateral, sometimes in bilateral effusions. Okay.
see this in this X-ray? Okay. What you can say? Can you read this X-ray?
Sir, the patient is having a very high opacity, that is there in the right, that can be appreciated in the right hemithorax, and
Read.
so this is a chest X-ray peer
No,
view.
not that. You said there is a right hilar opacity, homogeneous, non-homogeneous. Is there any silhouetting of the right cardiac border?
Sir, it is a homogeneous opacity, sir, and there is a obscuring of the right heart border here, and
You see that silhouetting is there. In the subsequent X-ray, there is complete silhouetting plus also there is involvement of the right lower zone in subsequent X-ray. So it has progressed. And Dr. Nair, as he said, upper lobe, upper zones and all they are spared. See, this is also spared. Very important. Right side there is right blunting of CP angle in the second X-ray. It is progressing very fast. So read like that. Silhouetting of the important. I'm able to understand where the lobes are important. And multi-lobar.
so these are the changes that we would be able to find if a CT scan would be done in a patient with atypical pneumonia. Again, in an X-ray, we will be able to appreciate the peribronchial cuffing in the case of mycoplasma pneumonia. If we were to take a CT, we will be able to appreciate the bronchial wall thickening, and nodules, micronodules, and tree and bud opacities are very specific for mycoplasma pneumonia. All three atypical mycobacteria will have granulous opacities along with consolidation, and interlobular septal thickening is present in the case of chlamydophila pneumonia.
So actually what will be a differential diagnosis based on CT scan, especially for mycoplasma, where you see, micronodules, where you see hello, yeah, because there is online streaming, live streaming is happening right now through YouTube. So I'm speaking on mic actually. So there is a nodule and tree and bud pattern, right? CT scan. You must have attended many radio conference, right? So what is the other condition where you will see tree and bud pattern in CT scan?
Sir, tree and bud pattern is suggestive of active infectious etiology that the patient could be having, could be a tuberculosis that the patient could be having, and other tree and bud pattern.
That is the most commonly discussed.
procalcitonin, this was a study which was published, multi-center prospective observational study, which was published in patients with community-acquired pneumonia. Procalcitonin as a marker, procalcitonin as a marker of etiology in patients with community.
What will be the focus findings that you have discussed, about this study? You showed that table. And if I ask you, the CT finding, the previous one, the X-ray finding, go to the X-ray table. Yeah. Or I put ultrasound. So what will be your finding, in this type?
Sir, it
Correlated CT, X-ray, computer. You got a question?
yes, it is. Sir, so
Sure, you can answer this.
sir, I'll go on case to case basis. If it was a regional pneumophila patient with severe pneumonia, we can expect localization of the lung also, and subpleural consolidation with shreds. B lines can be present, and if the patient is having significant pleural effusion, we can appreciate the jellyfish sign, and the spine sign can also be seen in the patient with pleural effusion. So, and,
Suppose it is mycoplasma.
sir, again, a low bottom consolidation we can appreciate with a program or a
Better to understand, you will have a better lesion in legionella pneumonia, right? And you see severe form, right? You will have pneumonia with bilateral. It is a severe form of pneumonia, most likely legionella, right? Chlamydia, pneumonia, unilobar environment, you say patchy consolidation.
low.
The predilection is that toward the lower if you have infection. But in the mycoplasma, what is your finding?
Sir, if our suspicion is atypical pneumonia,
Very difficult, we are
and
talking about non-coming to mycoplasma. What will be the focus finding lab?
only correlating with history.
The X-ray finding you
Ah.
have told the CT finding is the standard, right? You have reticular telemetry, blood pattern, all that stuff, right? What will happen when it is the investigation in the end? You understand the clue?
Again, B line, shreds with B lines will be present in this patient, sir.
Yes, there will be strong B profile, bilateral, most in zone 3 and zone 4. Okay? And you said peripheral pneumonia, that is what is that, right? Pneumonias, right? Interstitial patterns, right? Reticular nodular. So you have thick, very thick B lines and bilateral. As if it is mimicking like a IIT. Almost the definition of that, right? And then maybe associated with stress. You find predominantly that, and less of consolidate. Later on, they will also consolidate. You have to think about this. I'm just putting you the focus signs for this category. Because that probably somebody may find out, I don't know. But if you see the CT finding, X-ray, this should be the logical focus finding. Okay, go ahead.
So this was a multi-center prospective observational study which was published to find the role of procalcitonin in identifying the etiology of agents, identify the etiology in patients with community-acquired pneumonia. They found that higher procalcitonin usually suggested that the patient is likely to have a bacterial etiology of pneumonia, and among atypical pneumonia, Legionella, atypical bacteria by themselves have a very low procalcitonin concentration only. Among atypical pneumonia, Legionella will have a more procalcitonin concentration when compared to the other two agents, with a median value of 1.1 nanogram per milliliter as mentioned over there. the tests that are done in our AIMS. This is a series of 6 tests that are done in AIMS for atypical pneumonia. The issue is everything has a minimum turnaround time of a minimum of 7 days. So even if we were to send a test for atypical pneumonia, it will come only if the patient is admitted. So going to the treatment specific of communicable pneumonia. So we had already seen how to triage a patient with communicable pneumonia based on COP 65 pneumonia severity index. This is a table that I have taken from Harrison's for the patients who can be managed on OPD basis, or treatment of communicable pneumonia on OPD basis. So a patient who is not having any comorbidities or risk factors for antibiotic resistance. So there is one thing that I have to say. ATS and IDSA says risk factor for antibiotic resistance means that the patient has received parenteral antibiotics in the last 90 days. But Harrison says it is not just parenteral antibiotics, we have to consider oral antibiotics also. Oral antibiotics in the last 90 days. Harrison is saying we accept what ATS and IDSA are saying, but we are giving recommendations from our side also. You have to take oral if the patient has consumed oral antibiotics in the last 90 days, you have to consider that also. So if the patient is not having any comorbidities or risk factors for antibiotic resistance, you can go with a monotherapy of doxycycline or a monotherapy with a macrolide or a combination with amoxicillin and macrolide or doxycycline. If the patient is having any comorbidities, so what are the comorbidities? Patient is having chronic heart conditions, chronic kidney disease, chronic liver issues, and asplenia, diabetes, alcohol use. Then the patient will, these are the comorbidities that are specified over here. Then you go with the combination therapy of amoxicillin and macrolide and doxycycline for the atypical agents, or you can go for a monotherapy of respiratory fluoroquinolones, which can cover both. This is the treatment of communicable pneumonia on inpatient basis. So we have triaged the patient and we have triaged that the patient. So we have triaged that the patient would require ICU care or inpatient care, and now whether it is as per ATS and IDSA, we have decided the patient is non-severe pneumonia or severe pneumonia. So if the patient is non-severe pneumonia and does not have any risk factors, we can go with a combination of beta-lactam and a macrolide, or go with a single therapy of respiratory fluoroquinolones. If the patient has had prior respiratory isolation of either Pseudomonas or MRSA, then we have to give that coverage. If the patient is having non-severe pneumonia and patient is having history of recent hospitalization, then we will give anti-pseudomonal coverage or MRSA coverage only if our pulses are coming back positive for those agents. However, if it is a severe pneumonia and patient is having history of hospitalization, we give anti-pseudomonal and MRSA coverage even just by sending the cultures without waiting for the results. So this is a on lines of 80. It is on lines of 80 ideas.
No, sir. We have a separate guideline by Department of Medicine for antibiotic. No, because the reason I asked is even for curve 65 less than 1, according to that app which they have, they do not say amoxicillin, they say amoxiclav. You have to along with clavulanic acid.
5 to 7 decibel. So this was a meta-analysis of several RCTs which was done to find out if giving empirical coverage against atypical pathogens is effective. And they found out that there was a significantly lower rate of clinical failure if atypical coverage is given to patients with community-acquired pneumonia. In this, several of the RCTs, they are given fluoroquinolones as their empirical coverage. And they have found that lower rates of clinical failure with CAP is seen in Legionella and Mycoplasma, but not with Chlamydophila pneumonia. Here they are also mentioning that this has to be taken with but not with Chlamydophila pneumonia, has to be taken with a pinch of salt, because Chlamydophila pneumonia is self-resolving. Even without Chlamydophila pneumonia and Mycoplasma pneumonia, even without giving anything, the patient will become alright. So use your clinical decision and take the correct action. So based on this meta-analysis, it usually supports that we cover for atypical pathogens. So previous meta-analysis said that we have to cover for atypical pathogens, give empirical therapy for atypical pathogens. This is another meta-analysis which said which antibiotic to give, whether to give a macrolide or whether to give a fluoroquinolone. Again, this meta-analysis of several RCTs found that there was no difference. You can give either a macrolide, you can give either a fluoroquinolone with respect to atypical bacteria. So this is my next part. This is the next part of my presentation, which is on viral pneumonia. So the classifications of viral pneumonia, these include the influenza virus, COVID virus, and respiratory syncytial virus, measles, varicella zoster, herpes, cytomegalovirus. So these are the common symptoms that we see in a patient with viral pneumonia. Patient will usually have, it is usually associated with a non-productive cough. However, in severe cases, patient can have a frothy pink tinge sputum also. Patient would be acutely ill with conjunctivitis, rhinitis, conjunctival injection, and patient might have throat pain, secondary to tracheitis that he might be having. And on examination, patient will be having tachypnea, wheeze, and a variety of chest X-ray patterns can be present in a case of viral pneumonia. The most common being the interstitial pneumonia that we had, interstitial pattern that we had seen previously. And the risk factors for viral pneumonia include COPD, valvular heart disease, and other comorbid conditions like diabetes mellitus, hypertension, etc. So going to the agent in particular, influenza pneumonia. So this influenza pneumonia is characterized with rapid progression of dyspnea, cough and cyanosis, and the development of acute respiratory distress syndrome. And the chest X-ray, as already discussed, would have bilateral interstitial infiltrates. Here, the main problem would be the development of a secondary bacterial pneumonia that the patient would be developing. So how would the patient present? After dissolution, the patient would be initially
viral pneumonia based on the X-ray findings. Actually, it is very difficult. Most of the time, viral pneumonia having subpleural involvement. Any nodular involvement is there in upper lobe also, and very rarely it is associated with pleural.
So here in secondary bacterial pneumonia, 1 to 2 weeks after recovery, the patient will come back with fever and the symptoms of lobar pneumonia. And the treatment that is usually given to a patient with influenza, if the patient can tolerate orally, we give the patient oseltamivir, which is Tamiflu 100 mg as a PD dose. If the patient is having severe pneumonia and we have to give IV dosing, we go for Peramivir 600 mg intravenous dose. And Zanamivir is also available, which is through the inhalational route. there are 3 other drugs, amantadine, there are 3 other drugs, amantadine and baloxavir, which are not used currently because of their high resistance. Next is varicella pneumonia that I'm going to be discussing. I've taken this because the chest X-ray finding was quite peculiar for this pneumonia. So one different thing about varicella pneumonia is this occurs in a greater frequency in adults than in children. 25-fold greater frequency in adults than in children, and it does not mean that just because the patient is having a diffuse rash all over the body that the patient will have a severe pneumonia. The intensity of the rash does not correlate with the pneumonia, and it is a particular problem in patients with hematological malignancies and patients who are on immunosuppressive medication. It usually, the progression of the disease is 1 to 6 days after the onset of rash. Patient would come with complaints, respiratory complaints, and the characteristic pattern is a nodular infiltrate that would be seen on both aspects of the lung, which would progress to miliary calcific densities. And the patient could have peribronchial infiltrates, hilar lymphadenopathy, etc. Treatment over here would be a intravenous acyclovir. So this is the chest X-ray finding of a patient with varicella pneumonia, nodular infiltrates on both the sides of the lung. Oh, that's So my last topic of discussion would be COVID pneumonia. So COVID presents with a spectrum of symptoms. Patient would have just a runny nose, sore throat, fever, cough, and gradually will go on to developing dyspnea, and ultimately might develop hypoxia too. Other associated signs and symptoms include anosmia and loss of taste, diarrhea. And the risk factors for developing severe disease include that the patient is obese, patient is diabetic, hypertensive, other cardiopulmonary conditions, and immunosuppressive illness. Here the CT findings that we would be able to appreciate in a patient with COVID pneumonia is a bilateral ground glass opacity with patchy shadows, which is commonly seen in viral pneumonia only. And other findings that we can appreciate would be interlobular septal thickening and air bronchograms. So as far as the treatment of COVID pneumonia is concerned, we give the patient respiratory and circulatory support as required. Steroids and remdesivir is a anticoagulation inhibitor which is known to reduce the duration of illness in hospitalized patients. And tocilizumab is an interleukin-6 receptor antibody. It reduces the progression of disease, that is reduce the chances that the patient might go on to require ventilator support, but no difference in mortality is seen in the patients. So with this I complete my presentation. Aspiration pneumonia we can expect in a patient patient having a prior history of cerebrovascular accident, who's bedridden, who's having a Raynaud's tube, coming to us. And second, patient is a chronic alcoholic. Sir, on point of care, bacterial pneumonia is usually specific to one particular law, but a viral pneumonia would be diffuse, would have diffuse. And in a pneumonia that is secondary to a typical pathogen, we can expect a pneumonic effusion. We can expect a pneumonic effusion if present can be suggestive of bacterial pneumonia. And a bacterial pneumonia will have subpleural consolidation, hepatization, whereas a viral pneumonia will have shreds with big lines, rather shreds with big lines. And
What happened in COVID? Ultrasound findings of COVID. When we published the paper from our department, they did not